Hello, everybody. Welcome to Health or Consequences, the monthly Massachusetts health policy podcast of Commonwealth Beacon and Mass Inc. My name is John McDonough. I'm from the Harvard Chan School of Public Health, and I'm your host, along with my co-host, Paul Hattis from the Lown Institute. Today, we are going to be diving into and exploring the issue of physician unionization across the country, across Massachusetts, but specifically at Mass General Brigham, where an effort has been going on to unionize hundreds of primary care physicians. Our guest today is a friend of mine and a colleague from the Harvard T.H. Chan School of Public Health at the Department of Health Policy and Management. His name is Dr. Michael Barnett. He is an associate professor at the school. He's also an associate professor of medicine at Harvard Medical School, and he's also a primary care physician at Mass General Brigham. So welcome, Michael. Thank you for joining us today.
Thanks for having me, John. It's an honor.
So let me start with, could you, a little bit in terms of your background and career, what is it that led you on the path to be one of the organizers of the currently going on physician unionization effort at Mass General Brigham?
It's not a place I necessarily would have thought I would be in when I was in medical school. But as you mentioned, I spend most of my time as a health policy researcher at the School of Public Health along with you. However, I have trained in primary care and been practicing primary care now, if you include my residency, for over a decade. And I have had a front row seat to what practically any primary care physician can tell you, which is that healthcare has become more corporatized and financialized over the past 20 years, and that consolidation in healthcare is something that really affects almost all physicians. The era of the small practice and the solo doc that puts up a shingle and you walk into their office is, largely dead, outside of concierge medicine, that is. And it's really been in the past 5 or 6 years that I think, for me personally, the loss of autonomy and benefits and services that have been siphoned off from primary care have accumulated to a point that I look around me and I ask, who's going to end up helping us, right? Congress and my colleagues and policymakers at many different levels and think tanks, everyone's been talking about primary care falling apart for decades. You can read an article by Barbara Starfield, the late primary care scholar, of what she wrote about the crisis in primary care in the 90s, and it's largely indistinguishable from what we're dealing with now. And so the basic answer in terms of the unionization effort is, as I think through various options for how primary care can get better, I don't know who we can turn to except ourselves. And the US has a very long history of, in labor, when conditions continue to get worse and worse, and workers are becoming increasingly dissatisfied with their lot, organization is really the option. And I would want to pursue basically any other option if we could. But as of now, having many colleagues and friends who are health policy experts, researchers, very smart people, no one has really ever given me an answer to who else is going to help us besides ourselves. No one's been like, oh, well, actually, you really should do this first, because whatever they say, it's actually already been tried for a long time, and we are still where we are right now.
Michael, this is Paul Hass. Let me add my words of welcome, but let me sort of dive into some of the things you're talking about, because as you know, in our state and nationally, we're talking about the primary care challenge. But for you specifically at MGB, or you're at the Brigham, and you have colleagues across at least your institution, the Mass General, and maybe even some other kinds of practice setting sites. Can you tell us a little bit about who the group is that's trying to organize, and any thought about why it's happening now? Is it because the fellows and residents organize? Give us your thoughts about that specific to MGB, if you would.
Yeah, so the group that is specifically organizing right now is our primary care physicians, so MDs and DOs, who are employed by the Brigham and Women's Physicians Organization and the Mass General Physicians Organization. The way academic hospitals work is there's this funny structure where there's the hospital, but the physicians are separately employed by a physicians organization, which is kind of a parallel structure. There's lots more to say about that, but that's basically the defining unit for us. Of course, MGB has lots of physicians. There are primary care physicians, for instance, let's say, in New Hampshire or further west in Massachusetts, who are practices that are affiliated with our system and use the same health record, but they're not employed by the hospitals.
They wouldn't be affected by your organizing effort right now, then, obviously, since they're not an employment model.
Correct. So they're not a part of our bargaining unit. And I think your second question was kind of like why MGB or why now? So for the why now part, I would say that the unionization of the residents and interns is definitely a milestone event. I think it certainly has put kind of the norm of unionization in everyone's mind. However, I think that the thought process of who's going to help us, maybe we need to organize among the residents and the attending physicians kind of organically came up, out of the same factors. And so this was something that was on the minds of many of us prior to the pandemic, actually. And I think what happened, as it did for so many social phenomena, is the pandemic really kind of accelerated a lot of the problems that we had been worried about in our healthcare system, right? It accelerated consolidation, it accelerated employer exertion of control over our work environment. It made the work that we have to do more challenging and more time consuming for just, what it means to provide primary care. And we really just reached a tipping point, around 2024 when enough people said, you know what, we're sick of this. I could say for myself and for many other people, actually, one kind of radicalizing event was that Mass General Brigham at some point in 2024 decided that employees that worked less than 50% full-time equivalent. So for a clinician, that would mean that you practice fewer than 4 half days a week clinically, would lose all benefits. So they would simply get a salary and not have any other benefits. And this was not targeted to primary care, right? This was an MGB-wide policy. However, primary care, because of the difficulty of the job, has a disproportionate number of people that work part-time. And we were never actually told that this was happening. It just kind of happened indirectly. And we kind of just learned about it passively through, random emails. Just that particular event, for a lot of us, made it clear that actually MGB can simply completely disappear parts of our compensation package without any warning or discussion or rationale. And if they just do that without so much as a sorry about this, then what else can they disappear? And this is in the setting of many primary care specific issues where there were programs that we relied on that had been promised to us that either disappeared or never materialized.
Now, since you and primary care colleagues have announced your intent to organize, form a union, what have been the reactions specifically from the administration and MGB community? And do you and colleagues fear any retaliation or retribution for deciding to go down this road?
Yeah, so great question. I'll start with the good stuff, which is I think the reaction from the MGB community has been overwhelmingly positive. It's clear, not everybody is comfortable with the idea of unionization, and there are some people that have reservation, but there's just been an overwhelming outpouring of how is it taking you guys so long? This had to happen a long time ago. You guys get what you need. Go PCPs. Just huge support, both from patients, the general public, and colleagues throughout MGB. In terms of the system's reaction, it's been what I'd say just completely predictable. They're just following the same playbook that we've seen for the resident and interns union and what you'd see for really lots of organizations. So their playbook is they have tried to appeal and delay our process as much as possible. And their arguments really don't hold very much merit at all. But that's not really the point. They can still delay the process by putting up objections to the way we define our bargaining unit. And then they're also circulating lots of materials to the MGB audience about why unionization would be bad for them. And there are lots of talking points that really are rather misleading that we can talk through. In terms of retaliation, this is why we have the National Labor Relations Act that was passed by Congress. And retaliation for organizing is, in fact, illegal by federal statute. And so it would create a big enough mess for them to try to fire any of us or retaliate in terms of legal action that could follow. That so far they've been pretty careful, except following this playbook that they are advised on by the law firm that they hired, which is a notoriously anti-union law firm that just does this across the country.
So just a couple of details, Michael. How large is your physician organizing unit?
We are close to 400 primary care doctors.
400 docs across all MGB.
Within, the docs who are employed by MGH and Brigham.
Okay. And what union are you working with?
So we're working with a group called Doctors Council, which is a larger chapter underneath the FEIU umbrella. And Doctors Council is actually the oldest physician union in the U.S. The largest and longest standing union in the U.S. with physicians actually within the New York Health and Hospital System, which is the public health system there. It's actually very, very large, but they've been unionized, I believe, since the 80s, possible the late 70s. But they've been a vanguard in this forever. So our group is joining Doctors Council and proud to be a part of that tradition.
And what do you say to people who ask you what difference do you expect a union would make in terms of the experience of working as a primary care physician at MGB?
Yeah, so of course, that's why we're doing it. We want, as we say in our mission statement, our dream is that primary care should be the best job in medicine. We think it's the most important job in medicine, and it should also be the best place to work. And it's not controversial, I think, to say that not that many people would agree that it's the best place to work right now. And so we want happier doctors. We want more functional care teams. We want patients to feel like they can reach us and they are proactively getting the healthcare outreach and preventive health care that they need. And that also we have a very competitive PCP market where we offer great benefits and people really want to work here. Like, it's not that people drift into primary care because it happened to have an opening at the time. It's because this is the place to go. And we're MGB. We should be able to accomplish that. We are that for so many other specialties and areas in the region.
Now, Michael, you mentioned that there's 400 of you internal medicine doctors at the General and Brigham who are part of this organizing effort, but it doesn't include other hospital employed physicians who are specialists. You want to say a word about that, including how they're feeling about your organizing effort and how come you're doing this internal medicine alone?
So that is a great question. And it has broken my heart to get some forlorn messages from colleagues who are saying like, why didn't you guys include us? Like, let us in the party too. I want to make clear that our effort to organize right now is in no way making a statement that we wish to exclude or separate ourselves from our colleagues. We strongly believe that physicians, regardless of their specialty, have the right to unionize, and it is, I think, a long-term goal. But labor law requires that we have a community of interest, this bargaining unit, to negotiate a contract. And a few things around banding together physicians of multiple specialties make that just a lot more difficult. One, of course, it's harder to organize more people. Two, is that the needs of primary care physicians are somewhat distinct from other docs in the system, like say a radiologist or emergency room physician. We have separate clinical settings and separate details in terms of the things that we need. And the other thing is, we see that MGB is already trying very hard to split up a group that's actually relatively focused and kind of quite uniform in our working conditions and our management. They're already trying to split that up. And so we anticipated this strategy. And so we could be weaker if we tried to cast a wider umbrella and had both a weaker connection across our group as well as less cohesion. So this is really our foothold, right? This is our first step. And we welcome our colleagues and dream of being able to do that in the future, but we still have a big fight even to make this first step.
So across the nation, Michael, physician unionization is growing. It's growing, as you suggest, as the corporatization and financialization of healthcare expands and grows. In terms of your own work, do you see yourselves as part of this national movement, or are you much more focused on your own unit and your own place in MGB, or do you feel like you are part of a broader national effort? And when you get involved in terms of, if you win, getting active and together, will you just focus on wages and benefits, or do you anticipate that you'll be trying to influence other kinds of organizational governance issues and things like that?
Yeah, so there's a lot to answer there. So I'll unpack it one piece at a time. So the first one is the rise in physician unions and our position as part of this national movement. And I would say that we are absolutely aware of the national movement and our relatively early entry into this. And for many of us, really, it's actually inspiring that we want to be able to demonstrate to other academic health centers and other physicians that we can do this well, and we can establish a model that can inspire other doctors to come together so that they can have a seat at the table and get the working conditions and the ability to provide healthcare that got them into medicine in the first place. We're also aware that the world often pays a lot of attention to what happens in health systems and higher education here in Boston, right? We're Harvard affiliated. MGH and Brigham, arguably have international brand awareness. And so there is a certain obligation, I think, for us to really get this right and to be, a very positive case of how unionization can really work. And, we very much want to set that example and inspire others. The second part of your question was about, what we are thinking of focusing on, right? Like unions, like blue collar unions traditionally are very much about wages and, keeping up maybe, standard benefits with prevailing conditions and inflation and whatnot. So as physicians, we are extremely aware that we make a lot of money and that we are not claiming poverty or trying to bemoan our financial status as people who are suffering in the current economy. We're very aware of our position in kind of a socioeconomic hierarchy. That being said, it is really within everyone's interest to have a primary care workforce that has the most talented, engaged, excited, and productive doctors that we can. And we're in a marketplace where there are ways to do that and there are ways to not do that. So compensation and benefits are definitely our menu, right? Boston's a very expensive city, and our PCP payment has not really kept up with the national pay scale compared to Boston being one of the 2 or 3 most expensive places in the entire country. And then for benefits, one example is that a lot of PCPs are less than half time because they have kids, they have other jobs, they get overwhelmed by primary care, right? Having part of our workforce have no benefits underneath that boundary is just infuriating, right? It sends the message that MGB does not want us to work there. We're not valuable enough to get benefits. And so, that's another very concrete thing that a lot of people are upset about. That being said, those are 2 issues that I would say are not, they're not like 90% of our platform. There's a lot of other issues that we care about. We want more robust care teams so that patients get better care, and also doctors can spend their time with patients and practicing to the top of our license, right? Rather than always filling out paperwork or struggling with, finding the right provider for patients or other things like that. We also want to support our patients' health and have programs that can actually help us do a better job at managing and preventing chronic illness. So, for example, there's a lot of work necessary to manage things like high blood pressure or high cholesterol that are, in some ways, are very algorithmic. And we used to have programs that actually were very effective at doing this, and that got closed down because MGB decided it wasn't worth the money anymore. But the public health benefit is undeniable. And we also want to protect our professionalism and have a seat at the table. So, MGB, as part of a charm offensive, is offering they're trying to bolster primary care in our system right now, which is very welcome. However, it's also very clear to us, based on the past 10 years of history, that without a seat at the table in the union, as soon as MGB gets into financial trouble, those benefits, those extra team members or extra clinical services they're offering us are first on the chopping block if they need to save money. And that can't happen again, right? They need to go through us first. So those are some of the big issues, really. Having our own voice, advocating for our clinic and our patients, and then also making our workplace somewhere where the best doctors want to be.
So we hear repeatedly that primary care across the nation is in crisis. And it's also true in Massachusetts. We heard the governor say it. We've heard in her State of the State this year. We hear it repeatedly. Do you see signs of the crisis at MGB in terms of your own work and the work of people? What What does the crisis look like and feel like from your perspective?
Oh yeah, the crisis is alive and well at MGB. I think there's no question there. Many of your listeners probably heard about the story that was in the Globe about basically a whole practice in MGB getting up and leaving and going to Beth Israel actually because they were just fed up. That's very unusual in an academic medical center, or 10 plus doctors who could collectively take care of, say, 15,000 patients to just get up and say, we're fed up, we're all quitting together. We have seen incredible staff turnover in my own office. We see staff like medical assistants and nurses and our, extraordinarily valuable and talented front desk staff leave our office, not because they, get a different job in healthcare or, want to get a degree or something, but because primary care is just too stressful and they go work in a specialty office because it's just an easier way to work. We just have too much volume. Patients need to come to us for too many things, and it's just exhausting. PCPs are also leaving, retiring early, shrinking their panels. They're just doing everything they can to compensate for the fact that we just simply don't have the person hours, the person minutes to take care of our patients that the old model has, the status quo has kind of limped along. And our only way to compensate for it is just to get paid less. And instead of working 60 hours a week, we can work 40 hours a week, but we see fewer patients. In the MGB system, only a tiny, tiny fraction of PCPs are full-time. It's probably 15 or 10% or less, which is just showing you, just people showing with their feet, like what it means to be a PCP in our system.
Michael, many of the factors you just cited are not unique only to MGB. In fact, it's spurring primary care providers throughout the state themselves to try to organize and get state legislation passed. There's at least 3 different bills that have been introduced to the legislature trying to deal with the primary care crisis. What would you say to someone that said, rather than unionize, why not just join and be part of that legislative effort, to move things towards capitation and increase the resource flow into primary care? What would your reflections back to somebody that made that assertion to you?
Sure. So, I'm a policy researcher, right? Like my life's goal is to get evidence to evaluate and inform the best policy we can. The way I see it is that it's not an either or, right? Healthcare is so broken on so many levels that we really need both here. And I know you had Dr. Wayne Altman on your recent podcast. He is, one of the driving architects of the Primary Care for You, PC for You bill, which I think has the potential to really revolutionize primary care in the state. And if it goes through in its kind of idealized form, it really could make a lot of what we want as a union possible. However, health systems are also going to try to weasel out whatever they can that is going to be required in these policies, because that's what all healthcare providers do for any policy that makes them pay more or affects their bottom line. So we also need really strong unions to hold them accountable for what the policies are asking them to do. So for example, the devil's going to be in the details of the PC for You policy, but let's just take an example policy where the state says, okay, we're going to pay health systems a bunch more to help primary care. And if there aren't very strong controls in place, there's really there are very few accountability mechanisms to make sure the health systems actually take those dollars and invest all of them or most of them in the primary care practices, as opposed to handing out some little treats to the primary care practices to make a show that they're using the money, but actually using the extra money in other ways that don't benefit the primary care clinics in any way.
So you say being a union, you could, in your negotiations, insist if a law like that got passed, that those dollars actually flow through to help transform primary care practice in the ways that you guys see as beneficial to your patients.
I think, collective bargaining is one mechanism. So, that's one mechanism for accountability. But another mechanism is that we will be a union and we can call them out and say, show us the receipts. Like, we were supposed to get an extra, I'm making up a number, an extra $15 million for primary care. Like, where's that going? Because it's been a year and all we've seen is free coffee, And so, and that doesn't need to be a part of the collective bargaining. I mean, that's, its own complex, formalized process. But, right. We have a collective voice.
It's the bully pulpit role that you're saying, too, that comes with being a union. Okay, I know we're getting near the end. I think my colleague has a final question for you.
Just a little bit in terms of some important details. So the first step of starting a union is going out and getting people to sign cards to join the union. Are you through that phase yet?
Yes. So that happened in November. We got a super majority of eligible docs to sign cards. So we actually went to each and every one, and they filled out a detailed card with their information supporting the formation of this union, and we submitted it to the National Labor Relations Board, which is a little office in the federal building downtown. It's actually a person sitting there, and you hand them all the cards. And so that marks our official filing. And so now we need to resolve a legal dispute with MGB to be able to actually organize an election.
And any idea when an election might happen, or when that might occur or could occur?
Yeah, the regional labor board needs to have a session to basically adjudicate this dispute that MGB has raised, and we are fully expecting them to rule in our favor because of the lack of rationale behind their arguments. That we're hoping will happen sometime in May, possibly June, and then we could organize an election shortly thereafter. So our hope, if things go smoothly and we don't encounter other legal barriers thrown up by MGB, is that we could have an election by the early fall.
And it's standard operating procedure across the country for corporations that are facing unionization drives to do everything they can to stall and delay and push it forward. And it sounds like you're experiencing the same kind of response from the MGB administration.
Absolutely.
Yeah.
And I just want to add, even though corporations almost always do it, it is a choice. They do not have to. They could allow us to have an election and let our colleagues vote and let us declare what we want.
Since you have a supermajority, they could actually recognize you without even having to go to an election.
Correct. Yes, that's correct.
Michael, thank you so much for joining us today. On behalf of Paul Hattis, we appreciate your perspective and hearing from you, and good luck with your efforts. And on behalf of Paul Hattis, and thank you to our listeners for joining us, and we will be back again next month with another edition of Health or Consequences.